Namaste and greetings. I, Ishika Chaudhary, researcher at IMPRI, Impact and Policy Research Institute, Prabhav Evam Niti Anusandhan Sansthan, Nai Delhi, extend my warm welcome to you all to IMPRI #Web Policy Talk. Today, we have gathered for a special talk on the topic, The Gender Gap in Vaccination by Professor Vina Vaswani, as a part of the series, The State of Gender Equality, #Gender Gaps. As chair, we have Professor Vibhuti Patel, visiting professor at IMPRI, former professor at Tata Institute of Social Sciences, DISC, Mumbai. We welcome you, ma'am. With the permission of the chair, I would like to introduce the distinguished speaker and discussants.
Please introduce the distinguished speakers.
Professor Vina Vaswani is Director at Center for Ethics and Professor at Department of Forensic Medicine and Toxicology, Yenepoya University, Mangalore. We welcome you, ma'am.
Thank you.
As discussants, we have Dr. Mala Ramanathan, Working Editor at Indian Journal of Medical Ethics. We welcome you, ma'am.
Thank you very much.
And we have Dr. Medha Rajappa, Professor of Biochemistry and Associate Dean Research at JIPMER, Pondicherry. We welcome you, ma'am.
Thank you so much.
We look forward to learning from the esteemed gathering. And now I hand over the proceedings to Vibhuti, ma'am. Thank you.
So good evening, friends. First of all, I would like to thank Dr. Arjun Kumar and IMPRI team for giving us the opportunity to discuss one of the most mind-boggling issues of contemporary India. And I greet my academic colleagues and co-travelers in the women's movement, Dr. Vina Vaswani, Dr. Mala Ramanathan, and Dr. Medha Rajappa, and all the esteemed participants. We all know that currently it is hotly debated issue, the gender gap in COVID-19 vaccination. The persistent gender gap in this vaccination in India has been found even after proactive campaigning by the state and union government. About 47% of women have received shots, as against 52.5% of men who got them. The tiny number of transgender persons have also received vaccination. And this discrepancy in vaccination access has forced all of us to seriously examine multifaceted aspects of this challenge. What are the socio-cultural determinants? What are the reasons for vaccine hesitancy among women and girls? How many women in vaccine trial were involved or were inducted in the vaccine trials? Were they young or old or pregnant or women with comorbidities? The third question is that why is there like across the country and you can see the interstate variations in the vaccination rate, where we see that those who have a relatively lesser vaccination gap, they have been like Kerala, Chhattisgarh, Himachal Pradesh, Andhra Pradesh. While we see that some of the most important strategic places and even the capital city or some Uttar Pradesh, Nagaland, Punjab, that the vaccine gap is much higher, a gender-based vaccine gap. Globally also, if we see, it is the African countries where you see hardly 2% of population is vaccinated, while in the industrialized world, we see around 70% of the population which is vaccinated. So gender gap in the vaccine gap is there across the intersectionalities. Gender is one of the intersectionalities, and is user fee preventing women from accessing vaccines, or is universalization of free vaccine solution to eliminate gender gap? Did online registration also generate more impediment for women who don't have digital access? What actions are taken by the state to reduce gender gap? What has been the response of the public health system with regards to vaccination? Our generation is used to having a very proactive vaccination drive. When I was a child, I used to see, like, for whether it was a smallpox vaccination or triple antigen or tuberculosis vaccination, the state took very serious responsibility, and that of going like a door-to-door campaign, or at the schools where the centers, colleges and universities where the health checkup, medical checkup involved in verifying whether the child or a boy or girl has taken vaccine or not. Why don't we have this kind of temperament now? Why is it only those who are able to pay 800 rupees? They are the ones who manage to get vaccines. What has been the response of the private players? Why the massive naming and shaming globally has happened for the way private sector or the multinational and transnational corporations are not ready to budge from their intellectual property and the IPR regime, which is preventing the poor developing countries to produce a low-cost vaccine. Are the intersectional marginalities of caste, class, gender responsible for differential rate of vaccination among women of different socio-cultural and religious backgrounds? Do women have right to decide about their health, or their husbands or brothers or sons take the call? Because there are so many studies on health-seeking behavior in which we have found like that women, generally it is the family which decides what kind of treatment a woman will get, but not only with regards to pandemic or corona, but even for any other health conditions. Now, the same attitude we can see that is responsible in the vaccination gap. So in late June, like nearly 2 months after vaccination opened for all adults, women's share in total inoculation is 46%. And the fact is that even in last 3-4 months also, we see only 1.5% increase. Now, Union Health Ministry has several emergency meetings with the state governments. National Commission for Women also sent a letter to the Union Ministry and state governments, and it was shared with the health secretaries of all states and union territories. And but they were asked that they must take emergency measure to get more women to come for vaccination. And in Mumbai, like city like Mumbai, we saw that BMC twice organized ward-wise vaccination drive targeted only for women. Dedicated one Sunday was given in the month of September, and also one Sunday in the month of October was dedicated only for women's vaccination. So these are some piecemeal responses have been there. The center has been highlighting the gender gap in administering vaccination is significantly more among elderly population than among the younger women. Many women's rights activists have been pointing out that in many households, women's health is not considered priority as compared to that of men. And if they do not work outside home, like especially the housewives, and they end up getting less preference in vaccination. Now, these are different types of guesstimates that we are getting. Now, it is very important to have a scientific understanding on this issue based on ground level reality and hardcore data. Here we had three very renowned and very experienced scholars, Dr. Vina Vaswani, Dr. Mala Ramanathan, and Medha Rajappa. All of them will highlight different important crucial aspects of the gender gap in vaccination. So the first presentation, the special lecture, is by Dr. Vina Vaswani, and I request her to make her presentation. Over to Dr. Vina.
Yeah. Thank you. Can I get the screen, ma'am? Yeah, thank you. Yeah. Good evening to everyone. Whenever I have spoken here on this platform for IMPRI, along with under the umbrella of Dr. Vibhuti ma'am, it's always a feeling of learning more than speaking, because the overall exchange of information and discussion is the highlight. And with that remarks, I would like to thank IMPRI, the director, Vibhuti ma'am, and my co-panelists as I begin my discussion regarding the gender gap in vaccination. As and when I go through the presentation, I will keep in mind the time, as well as I'll try to bring in from my experience what I've noticed in gender gaps as per the access to healthcare, access to certain areas like tubectomy and other things, and why the decision making is not left to a lady, even though it is her body and it is her reproductive right. The rights remain as rights, like we keep something in a showcase, never to remove it. So I shall be bringing some of those experiences. So I will be talking about the social determinants in vaccination, and also the vaccine hesitancy in short, but then approaches to vaccine policy, what are the ethical approaches as such and what's actually happening, and the vaccine trials in girls and pregnant women who we are supposed to protect, when we exclude them and then we say, oh, it was meant to protect, but we're unable to protect because we didn't take you in the trial, right? So these are the things that we will discuss. And those transgender person for whom our heart goes out, that there is not even a mere lip service when it comes to research and their participation and their beneficence towards them. And I'm leaving it for the certain issues of how the vaccine acts in the body, what do the female or the female's approach or the look decision regarding the vaccination, which will be talked by Medha, and with the absolute facts and figures, Mala will be rounding off this discussion, which will be facilitated by Dr. Vibhuti ma'am. So, in the social determinants, the household living condition is a significant factor, especially in the slum areas. There are less access to healthcare services in general and also to immunizations because their need would be something like a roti, kapda, or makan. And if you want to include them in a service, it has to be done at the level of discussion to build a trust gap and then go and to give the delivery of the services. Actually, a study in Delhi found the higher quality of roofing was found to be more positively associated with overall vaccination rate. And household income plays a major role again in access to the vaccinations. Now, when I talk about in reference to certain papers, it's also possible that you have an alternate viewpoint because you are looking at some other paper. So we are open for discussion. It's not that what I say is what I strongly believe, but from what I have read, this is what's my perception. So regarding the parental education, maternal education was found to play a very important role in the use of healthcare services for immunization. But now what happens with maternal education itself? We are talking of gender, where the girls are the first one to be removed from schools, not today, 10 years prior, 15 years prior. So we have a huge deficit where education of the girl child itself. So when she goes to become the mother and head of the family, if she's not well equipped with these ideas, it might be detrimental for vaccination. So religious and minority groups, why do they feel so secluded? Because we are making them feel so. The way we peddle information through the media or through WhatsApp, which light travels around the world while truth is putting on shoes. So we make very sure that certain the sleaze counts, and so religious groups and some cultural factors affect immunization because they feel they are not a part of the larger discussion that's happening. With the marginalization, who get alienated from society. Now imagine the plight of the migrant workers who left and went from place to place. They walked. And then when we are now talking about vaccination and we are making compulsory the Aadhaar card, what if they didn't carry the Aadhaar card? What if they didn't receive the Aadhaar card? It happened with a lot of transgender population who underwent gender correction surgeries, whatever they wanted to, but then Aadhaar card is not changed because that time they did not receive. So now the name that they are giving, which I'll discuss in later, how it is so detrimental to what is in Aadhaar card and it doesn't match up. And then the migration of people. So this was my marginalization as well as migration has led to decrease in age appropriate vaccination in the migrant population. And the gender based inequity. The more we delve in depth, the more we know the gap is increasing. But we now need tools how best to bridge that gap. Because women depend on men socially, economically, and culturally. And they're put at a disadvantage for services including preventive health care, vaccinations, in fact, even in abortion services that they required, the contraception services that they required. I started my career as a medical officer in a postpartum center where I was giving contraceptives, advising on contraceptives. And when along with that, we had to cover the vaccination. So for under 5 vaccination, we used to take our van and go into community. But the moment we entered community, people used to run away from there and hide somewhere and come back after we have gone with our vehicle. The fear that they associated with vaccination was a lot to do with us trying to just have numbers, us not wanting to do anything good for them, but then we get some grant for which we have to do it. And there had been a lot of misinformation about what vaccination can do, which will again be talked by Medha. So women's role and power. So maternal, again, education, we talked about it, and parental adherence to vaccination programs. A lot depends on whether we believe vaccine to be useful to us in building up immunity and preventing from the diseases, or underplaying the role of a diseases when afflicted. But it also depends a lot on how we impress others in a negative way not to be a part of the vaccination drive. So, and social support works combined with education and communication for women. So when we are having so much importance on women's literacy, but yet during the COVID times and even before that, the school dropout rates have not increased. So is it that we are giving a piecemeal information and not a comprehensive information? Or we are not able to connect to a family what are the essential ingredients to have a robust family healthy life? And then the program accessibility to immunize, because especially with immunization and its utilization of services, like I said, as a postpartum officer, we also had to do contraception, tubectomies. We had our own targets, but my idea was you can never run after a target because you will not get it. It becomes elusive. Instead, if you go to community for a sit down talk and give what they have in mind, we have a better rate of people believing us and trying to ask us contraceptive advice. In one such occasion when we had talked to a husband and wife team, they had agreed on tubectomy. I was very new in the field, maybe 2-3 months. And next morning when we were preparing for tubectomy, I saw nearly 8-10 people at the doorstep asking, who gave you the permission? Who gave you the right? I said, but the husband, no, husband is the youngest one. Did you not ask him? He's not the head of the family. You should have asked the eldest brother, because the eldest brother owns the farmland. You did not ask. Okay, you are young, you don't know anything, but you should understand our ways before you suggest anything. So it's in other ways, the way we dialogue, maybe how can we best use the efficacy to dialogue, at the same time understand how best we can empower the families. That's between husband and wife and what you have to do. So many a times you have the best of the programs, you have the people there, but does not have enough takers. So I'm still looking for that magic bridge that can, or maybe through hard work, understand what the other party has in mind to build such a thing. Again, financial factors, country level financial factors impact vaccine dissemination. And I think we needed a little more seriousness. And I do agree with Vibhuti ma'am when she said the kind of vaccination drive we saw many years back, especially from 74 to 75, there was a huge increase. And 75 to 2011 was a huge jump, actually, steeply it increased. But we do not have that kind of door to door discussion and encouraging people to vaccinate. And when they go, no, it is just finished. So now today the internet is not working. So I have seen my own people who have gone for a long time, but then internet is down, so they've come back. So then do we think of other ways beyond internet? Just because you cannot feed in, so you're depriving so many people, you are asking them to come 3-4 times, but they're not been able to come because every time they come, they have to lose their meal. So the vaccination gap between the low income and high income countries could be because of one such factor. Now, during pregnancy, healthcare professionals recommend influence, because we generally think that it's good, vaccination uptake is good, but what about the other lifestyles, awareness regarding particular vaccines, safety concerns? How much have we talked to the pregnant women? Now, if you look at framework, what policy we should have had, generally, we go for India being a very resource limited country, a utilitarian, maximum good for maximum number, where social contract approaches states authority, which is on the collective will, of the community, because if I get vaccinated, everyone gets healthy or they remain healthy, because I'm indirectly promoting someone else's effect, which is beneficence. So that measures the welfare of the citizens. That's how the universal program of immunization also was there. This also should have reached to that level of universalization. Whereas some liberal countries, some of people think that we don't have to give up our autonomy. We'll just see when it is required. It's like a harm principle of Stuart Mill, that those who are downtrodden, if they are harmed, then we should not get into such position. But we should just see that generally everyone is benefited. It should be rightly exercised so that every member in the civil society will be benefited, but at the same time, you should not go against the will of the others. But now with libertarians, like we have in certain countries, they have stuffed vaccines. They're now going to discard it, dump it. They're not ready to share it with others. But then that is because of I, me, myself attitude. I have a right not to wear mask. I have a right not to vaccinate, which in turn they influence others, youngsters, teenagers to believe that we can be superhumans without taking a vaccine. It could be an individualistic point of view, but the authority for a public health is lacking. There comes a balance between the autonomy and the public health. And whenever in such pandemic situation, the public health should reign. It would override the autonomy of the person. Wanting or not wanting is not the question, but where there's a maximum beneficence. So, this is one such example where they're hoarding vaccines, which much more than what they require, but then the people are not getting vaccinated. Because the one example is in 1974, the World Health Organization, when they had the expanded program of immunization, initially it was to ensure routine vaccine to all the children. And when it was considered complete, when the third dose of DPT was given. And in 74, only around 5% of people were immunized with third dose of DPT, which moved in about 3 to 4, in about 10 years time or 20 years time to 79%. But in 2011, the goal was to reach a sustained national coverage of 90%. And among the 194 WHO member states, nearly 67%, more than 90% the national coverage. They were able to do it. But what is interesting, if you observe, more than half of all incompletely vaccinated children lived in 3 countries: India, Nigeria, and Indonesia. So what is it that we need to look at? Why India was hesitant could have also been a study since then, that hesitancy is not new. But we need to now look at it in what is the root of that hesitancy. What is causing, whether it's a trust deficit, whether it is because we don't approach, or there are fallacies about vaccine, or there is a information that is peddled, or they're so afraid of what vaccine can do, whatever. But that is a good scope and should have been utilized well when we were almost like contributing to 35% of total immunization cover not being there then. So strengthening routine immunization services, especially in the countries with the greatest number of unvaccinated children, should be a global priority. Now, pregnant women in clinical trial. So we said they're vulnerable. But vulnerability is not to exclude them from research, because COVID does not look at the virus, doesn't look at pregnant women and say, okay, let's not attack her, let's go to somebody else. She has every chance of getting a COVID. And if she has a COVID infection, then the consequences are much more deleterious. So we need to plan something that gives a cover. So the clinical trials should have also been done. But from a review of a US clinical trial registry, it was found that most clinical trials excluded pregnant women. And those which included were more only on the observational studies and not on the clinical trials. Considering the scale of this global epidemic, and future epidemics, public health obligation should be to include women in treatment of vaccine trials and to identify and implement appropriate preventive care. Because instead of giving an appropriate preventive care, we would rather not take them in a trial, is not doing justice for them. So some of the in the Forbes India at least that showed about the Union Ministry depicts 14.9 crore women against 17.48 crore of men who received COVID-19 vaccine so far. But of the factors that were not so useful for going for vaccination or that deterred from using the vaccination was because of lack of transport, insufficient number of vaccination centers, and online registration, adding a plight of women in the rural and urban areas. Every time a lady goes to get a vaccine, she has to make extra efforts to keep the food ready should she get delayed. And if the man says, no, no, don't go today, it's not a good day, or somebody is coming, so it's gone. So many a times, in fact, I know of a lot of senior citizens who have not been given vaccinations. For this simple reason, the children believe it's not required. Children believe you don't go out at all. Why do you need it? So the question of whether you think vaccine is a tool for better health, vaccine is a tool so that even if you get COVID, to a great extent, the complications are allayed or they're downplayed or diminished. So unless we believe in that, then we would still be having a lot of people who are not vaccinated. And many times in women's health, it's a non-priority issue because they are not breadwinners. They don't go and do anything. It's like she's just a housewife. But just a housewife, she cooks meals. If you were to buy it outside, you would spend lots on it. So these hours that a woman works, but she doesn't get credited for that, it brings a lot of injustice for her. So the gender gap is further exacerbated by spread of information, misinformation. And most of the misinformation is something to do with reproductive prowess, something to do with infertility or menstruation and other things. So in short, I'm just trying to tell you that the one is not deterred from entering into the clinical trial, but rather even the SIOM's guidelines, they say women should be included in the childbearing age. Otherwise, you have to justify their exclusion. Vulnerability should not be a part of exclusion, but rather what benefits can go to her, what other things can be provided so she can be safe. Special care, consideration in terms of research, informed consent process, risk benefit assessment, and adequate time and appropriate environment. These are important. Similarly with consent, just because we say she's a woman, she may not understand the language or something, you would rather remove her from the study. Whereas some cultures require spousal permission. For tubectomy, I had it very hard when the husbands used to fight and say, you wait, you wait. We waited sometimes for 6 weeks. And when she came back, the lady would be again pregnant. No, 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 we don't believe in abortion. So let's have this 8th child. Then later on, we will think about tubectomy. It is not that I was very zealous about doing tubectomies, but I was thinking I'm counseling. So am I falling short of my counseling, or am I not understanding them in a way that they're trying to trust me? So it should, even though you're taking a consent from others, it should not be a substitute for individual consent. And inclusion of women, even in the childbearing potential, they should be given opportunity to participate and inform about the risk to the fetus. And women as research participants, sponsors and researchers should provide access for the tests, including contraceptive measures and safe and legal abortion. Now, if we want to have a shortcut, we would say, why should we incur extra cost on them? But at the same time, when they do get pregnant, sometimes they go out of the follow-up. And we are aware that they're not coming for follow-up, but we are not putting proactive efforts to find out, make a follow-up, give the advice, and at least see what happens, in what way we can help. So if this is about when they become pregnant, what should be done, but we are now looking at even the pregnant and the breastfeeding women in research should be given adequate protection and made to be participant in research if they are willing. As a general rule, health-related research involving participation of women, unless it is potential harm to the fetus, it should not be conducted. And if it is conducted in the settings that are totally guarded, safe, timely, and a woman knows about the risk that she's taking. Now we come to, I'd like to ask Vibhuti ma'am, how much time do I have before I find her?
Can take another 5 to 7 minutes.
Okay, ma'am. Okay. Because actually, when a professor gets a good audience, it just can go out, out of the way. I didn't want to do that. But this is something that I'm very passionate about. People living on the thin edge of dignity, our transgender people. Those that get brushed under the carpet because they're transgender. Guilty of neglecting transgender as a whole, not only for COVID, in the healthcare and in research. Ask anybody what their experience is. They get admitted into the hospital. First they say, no, she's female, so let's go to female ward. No, she looks like man, let's go to male ward. Now in the male ward, no, we don't want she looking female, so you better put her back in the female ward. So what should happen to the dignity of a transgender person? Have we even considered any of us could have been in any of those places? But no, we would think they don't require much of our time and attention. COVID-19 has disproportionately affected the transgender population because of disparities in the income, in housing, and healthcare access. And those who have been rendered homeless have had the worst deal. They have been exploited at every level. Because we work closely with the community, we are aware of when somebody wants to give a house on rent, everybody else pays 3,000, but to these people it is 6,000 or 5,000. Why? Because you're not like us. I don't know what all activities you may be doing. So this kind of inherent bias that we carry is same with every human, most human beings. And so they get out from the healthcare as well as from the trials. So this happened even during just before the lockdown. Some of them underwent surgeries and they get reassigned to another gender, and they did not get a certificate. And they said, we will post it to you later. So these people have paid money and then they're not getting certificate. They're making calls to the doctor. Doctor is busy. He won't take your call. And then he's telling, oh, that certificate, now what is the use? Let it be. I will give them later. Now, because the certificate is not there, they cannot get hormonal treatment. It cannot start unless you give that certificate. So can you imagine what is their life's goal? Where are they going? And what support systems they had? And in COVID times, especially, when they depended so much on the Aadhaar card showed another gender and it showed another address and they were somewhere else, and it created a lot of problems for them. So the transgender people also mistrust the medical system. In particular study, more than half the transgender adult agreed that they would have got vaccinated at 2021, a higher rate than the general adult population. But they still did not have that much confidence. It showed a less number of vaccinations, also because by race, there was a lot of discrimination. Again, here, Vibhuti madam talked about intersectionality. So here, if you're transgender, if you're a white transgender, you have a better deal. If you're a black transgender, you don't have a good deal. And if you're transgender from a high economic strata, you're okay, but you're from a low economic strata, you're nowhere. It's just like a woman who is a housewife, who has not been educated, who wants to have a different aims and goals, but she will never achieve that because of the intersectionalities, which only result in her losing power at many of these instances, but none of them is empowering. So even the LGBT people of color and transgender people overall were worried about the affordability, effectiveness, and the side effects. In reality, studies looking into discrepancies in COVID-19 in the vaccine related to, between the nobody has done this study between transgender and cisgender. We just do about cisgender because we are all belonging there, but transgender we haven't had much clue about it. They are on heavy hormones. They are just converted. And if you don't do a study on them, how are we even going to discuss how they would respond to a vaccination without sufficient inclusion in the clinical trials? And another thing that happened during the COVID-19, during the vaccination, was also the Aadhaar card linking the legal papers, which did not talk about the sex that they were into, but rather earlier sex. So this is called dead naming. Dead naming and exclusion during the pandemic research, because when a transgender person is addressed by the earlier name and gender, he has made efforts to come out of that raw pain and literally being disowned by society into a newer identity. And here we are calling them the earlier name and sex. So they are totally crushed. They're crushed, I mean, because they feel that the society does not respect them for who they are now. And this happened a lot because the earlier legal papers were with them, and for a long time there were no new cards being made. They were not being given the cards. So when they went with that, with the kit and everything, there was a difference the way they looked and the way the card showed. So I think somewhere we do consider, or we do think, we owe every person on a big deal of ethics and reasoning, and we cannot have a huge number of population totally left on their own without a thought as to where the next meal would come from. And in fact, we are criminalizing them, but we are quite to pick up faults with them. So the efforts of transgender person to root himself in new identity created, which is totally destroyed by bringing up his old identity. So that is why it's very sensitive to ask a person how he would be addressed. But because of this legal papers and Aadhaar card, this added a lot of trauma to them. And researchers in most institutions, and along with institutions, they believe only in the male-female binary. They have still not grown to the extent of accommodating a gender beyond binary. So delay, and these are the things that could cause a lot of problems. So I've come to the end of my presentation. To conclude, in order to avoid pitfalls of ignoring sex and gender, we need to have a general sex gender sensitive approaches, and the research should be structurally done and should be implemented by registering the clinical trial. This should be made mandatory, and it will ensure that the research does have a sex and gender differentials. Otherwise, the researchers, even the data that was disaggregated, did not have much about the gender. So the COVID-19 sex-specific mortality brings to light the implications of incorporating sex-specific variables in the beginning and not as an afterthought, which was done much after it was done. Then you go try to dissect along it, and you do not get what you really are looking for, because in the first place you never made provision for it. So I would say that we do need to look at research not as just favoring certain class of people, but everyone, all inclusion, if everyone has to be benefited. If everyone has to be benefited, then the policy should be in place which is universalizable, that everybody can access. And to make that, we should put extra effort of talking and building, gaining their trust. So with that, thank you. And I'm really sorry I did over 8 minutes. So thank you.
Okay. Thank you, Dr. Vina Vaswani. I think you raised some of very important point, that overall subordination of women in the family, community, society, and economy. I think that has very much to do with women not getting equal access, and also they don't have decision-making power. That is also very strongly related to overall subordination and also the gender norms in our society. And also women getting less priority in health services, which is overall health services also, and here in a specific context of COVID. And in a context where 70% of corona warriors are women, okay, even it is admitted by WHO and UN. And when it comes to service providing and putting their life at the risk, women are at the front. But when it comes to access to safety, that they are neglected. And I think special mention about transgender populations, their stigmatization and exclusion, I think that is also very important. It's everywhere it is found. Same is the experience of the relief workers who were, so in all type of accesses, not only this, as you said, that is a housing and food and vaccination and the kind of bureaucratic anomalies that we have in our system, that also took a heavy toll. Now I would turn to Dr. Medha Rajappa, What has been your experience? Because Pondicherry is supposed to have a relatively less gender gap, though it is there, like it's a more only, but as compared to other states, Pondicherry has shown a better result. What kind of problems do you find at a ground level? Hello? Yeah. Madam, please unmute yourself. Yeah.
Yes, please unmute yourself.
Can I share my screen, please?
Yes, yes.
Are my slides visible?
No, poster is visible.
Okay.
Yes, that is slide on. Yes, ma'am, it's working.
Yeah, it's working. Yeah.
So very quickly, I will, a lot of ground has already been covered by Professor Vina. So I will very quickly just start with an overview of what is the scientific basis, what are the factors affecting vaccine protection, what are the challenges to vaccine success, what is the female gender and vaccines, then a little bit about cultural mindset and vaccine hesitancy and how we can overcome. So very, very briefly about the scientific basis of vaccines. I think I can very quickly go through this. All of us are aware that vaccines are biological products which help in mounting immune response against a particular microbe. We know that while it helps us to fight the infection, it reduces the risk of complications and death. In short, it activates our immune system without making us sick. And it has transformed the public health landscape, and many diseases for which vaccines are available have essentially disappeared. Today, the need is to develop vaccines for such diseases which threaten global health security, such as COVID or Ebola. And we all know that vaccines act by making antibodies, and the antibodies also have an immune memory. Therefore, the second time you meet with the same antigen, the body is able to effectively fight it out. And this also leads to herd immunity, where not only it fights the infection, it can also help in preventing the colonization or asymptomatic infection. Thereby, it reduces the transmission of a particular infectious organism, and thereby it establishes the herd immunity, which is the buzzword we have been hearing about COVID. So even if everybody cannot be vaccinated, the herd immunity can be developed if a sufficient number of people are vaccinated in a population. So what are the factors which affect the vaccine protection? Of course, what we get from our parents, the genetic factors, the environmental factors, including the age. And of course, in children, primarily the vaccination takes place in the youngest age group, less than 5 years of age. There, the maternal antibody levels, the prior antigen exposure are things which affect the vaccine protection. So vaccines will work provided they can be used. So the access to the vaccine is the limiting factor. There is an absence of health infrastructure in many places, lack of adequate amount of vaccine, lack of the financial resources to purchase the vaccine. This could be at a local level, regional level, or at an individual level. And of course, marginalization of certain communities, which has already been discussed. And of course, there are other peripheral factors such as non-availability of a cold chain to make the vaccine useful. And certain vaccines which are administered orally require less skilled manpower, but injectable vaccines require more skilled manpower. And the most important challenge to vaccination success is the dangerous role of the WhatsApp university and the social media, which provide spread of misinformation about the vaccines. But are scientists also at fault? Definitely, yes. They are sitting in their chambers and they are not reaching out to the public, sharing their expertise in a layman language, telling them why the vaccines are important. And of course, the genetic diversity for certain organisms such as the COVID, we are finding it difficult in order to change with the changing vaccines. So quickly moving on to the female gender and vaccines, it is already known that females are less susceptible to viral infections. This is because we have an extra X chromosome and therefore we have a protection due to the X chromosome as well as the female hormones or the sex hormones. And though the female gender, there is a gender gap, so therefore the availability and the acceptance is lesser in females. But once vaccinated, they develop a long-lasting immunity and a more protective response. And therefore, even the complications are more in the female sex as compared to the male gender. And in pregnant mothers, which Madam already mentioned, the vaccination is so very important because the vaccination is problematic because of the immature immune system in the neonate or the born child. And there is a presence of inhibitory maternal antibodies in the child. So vaccinating pregnant mothers is so very important to transfer the antibodies across the placenta to the child, and thereby it protects the child for the first few months of life. However, we do have certain cultural mindsets which affect our acceptance to taking the vaccine. Few things which all of us are familiar with, such as during the eclipse, we've all been told pregnant women should not go out. We've been told eclipses are bad. They are dangerous for expectant mothers. They should not use knives before, after, or during the eclipse. And we are also told not to see the sun during a solar eclipse. Now, how much of this is actually true? We all are aware that eclipses are only celestial phenomena. So this is totally baseless. Eclipses are dangerous. I don't think so. That has no scientific basis. But definitely in the olden ages, there was no electricity available. So probably there was darkness all around. So probably women, they wanted to rest more and therefore not to use any sharp instruments. And gazing at the sun is not good for anybody during a solar eclipse if you don't want to injure your eye. So vaccine hesitancy, there have been several surveys. Few reasons which have come forth are concerns for side effects, waiting for others to get it first. Other people need it more than me. Anyway, they're not going to be beneficial. I don't believe in vaccines. So these are the major causes. Cost of vaccines, which we thought is a limiting factor, and religious beliefs remain minuscule reasons for not accepting the vaccine in India. And males, as expected, have more acceptance, and those with educational levels are more vaccine acceptant compared to vaccine hesitant. But some religious beliefs which have spread the mispropaganda rather, that vaccines lead to impotence, they affect the menstrual cycle, they reduce the fertility, is totally baseless. And therefore, the center and the governments have to run intensified drives to dispel this kind of propaganda and the WhatsApp universities and remove the wrong information about the side effects. So the gender gap in vaccination, is it only due to the skewed gender ratio in the country, or are there other reasons? This has already been dealt with both by Vibhuti madam as well as by Vina madam. We all know that women's health is not a priority, especially if they are at home. The male members always get preference for the jab. Though the women are the primary caregivers and therefore they may be more likely to get infected, they are not considered important enough to take the jab. Many women don't have freedom of movement. They depend on the male members to commute. They need permission from the males, as well as this kind of vaccine misinformation, which I already told has been a problem. And of course, they believe that there are some social taboos which say that access to the internet for women is not good. So women are not tech savvy and therefore they are more dependent on the men to use the COVID app. Therefore, this is also one reason for the gender gap. And we all know that COVID-19 has not been good to women. There is more gender-based violence, more school dropouts, especially the marginalized sections. They have suffered. And therefore, we need to learn lessons from the polio and other campaigns to have a multi-pronged approach to overcome this gender gap in vaccination. So few things which can be done are an effective social and behavioral communication advocacy. We can promote the benefits of vaccination and fight the WhatsApp university and the social media propaganda, which is false. You can have skits, dramas, street plays, flash mobs with college students in the nook and corners of the country, telling them what are the benefits of vaccination. You can use school students as advocates to get their parents vaccinated. You can use panchayat members You can have TV and newspaper advertisements to curb the misinformation. Have pro-vaccine campaigns in social media by the government. More important, they say that if you cannot take the women to the vaccine centers, bring the vaccines to the women doorstep. So have mobile vaccination centers, have Anganwadi vaccination. Like Madam has already mentioned, the door-to-door vaccination in Bombay. Use the walk-in vaccinations where COVID registration may not be necessarily important. Rope in the peripheral workers who work in the PHCs, the ASHA workers. They have an extensive network with the community. You ask them to convince the community members in the villages and incentivize them for every shot which they encourage to administer. Involve the MPs, MLAs, the elected representatives, the women leaders to mobilize females. Last but not the least, use the self-help groups to create and mobilize awareness amongst the household. This will ensure that women and marginalized sections of the society are not left behind. I have largely drawn from these scientific articles and these websites for few of what I shared today. Thank you very much for allowing me to share my views here. I would like to say that unless all of us join together, the scientific and the non-scientific groups of society, we will not be able to address this kind of differences which promote the gender gap. So I would like to advocate that each of us around us, we advocate what small baby steps we can undertake in order to prevent the gender gap. If each one of us takes care of people around us, maybe our domestic help, maybe our people in our apartment, maybe the elderly, maybe the females, if we can arrange for, say, the mobile camps or have a door-to-door vaccination, if each of us contributes in our own small way, I am sure that the tomorrow will be brighter and better for all of us. Thank you so much.
Thank you, Dr. Medha, for giving such a comprehensive socio-economic, cultural aspects and the myths about vaccination. And I think these myths are there even for many other health conditions, and especially the myths regarding pregnant women. And also, what can we do as a civil society organizations, the community-based organization, local self-government bodies, and multimedia approach, and I think multi-pronged approach, which you suggested, is very important. Now, I would like to ask Dr. Mala Ramanathan that recently our minister, he said that by December 2021, we shall be able to vaccinate full population of our country. Do you think that this thing is possible? That means we will need really more than 1 crore people should be vaccinated per day if we go by that promise. And it should not be restricted on only special occasion where Prime Minister's birthday or this thing. So what do you think that this union government's target achievable according to you?
Good evening, Dr. Vibhuti and friends at IMPRI and other places. I'm glad you asked me the question, but I have to tell you that, you know, everyone has looked at the gender gap or even the vaccination gap.
Yeah.
It's in general, you know, gender gaps come after that. And I started only because, you know, you and Dr. Vina, I'm very grateful to you for asking me this question, because it took me back to my basics, that is the demographic training. And I brought the very basic, simple tools to revisit this question using whatever I could easily access. So, you know, I have to say that this did not call for extraordinary efforts, because to be very honest, there is a huge data gap. You know, to be able to identify a gender gap, it's one aspect of it is to have a substantive understanding of gender and its implications for access to healthcare. But to know the exact amount of that gap and we might know here why such gaps exist, but how much is it and what causes it? You know, you need a more comprehensive database that is open and available to researchers and everyone else, you know, to educate themselves. And that itself is something I've realized, thanks to all of you, is also another gap that needs to be bridged. But having said that, let me tell you why we need to look at this gender gap. Sir, would you care to move to? I need to place a disclaimer. I am a faculty at Public Health School in South India, and I'm also the working editor of the Indian Journal of Medical Ethics. But the computations and the opinions I'm expressing are my own, and they are not representative of the institutions that I'm affiliated to. And in a large chunk of the computations, quite a few of my PhD students, Dr. Gurpreet Singh, Dr. Bevin Vijayan, Dr. Tijo George, and Mr. Jishnu Pravan have assisted me today. So I need to acknowledge that with great gratitude, sir. Why is it important? This is a very, very crucial question that we have to ask, and I'm very grateful that why it exists has been so comprehensively laid out by Professor Vibhuti when she set the background for this discussion, and for Dr. Vina Vaswani for giving you the nuts and bolts of the gender gaps. And to Dr. Medha Rajappa and Dr. Vina Vaswani on, you know, the existing for addressing the issues related to these gaps that originate in our research itself as well. This is important because the vaccination gap in vaccination falls between the intersection of biological construction of women, which is what Dr. Medha Rajappa was talking about when she said things about the X chromosome and the intrinsic advantage that women have in resisting viruses. But having said that, does it overset the huge social disadvantage that emerges out of the social construction of being a woman? And that's what you're possibly seeing demonstrated in the gender gaps that are, you know, becoming explicit, but not because of any effort. It's because you have to go and dig this out to determine the gaps and find out, you know, finding out what specifically are the factors. They are so intertwined that it is so difficult to disentangle. But I'm going to try to point out some of it on the basis of existing evidence. Biological process could be partially gendered because women, especially in reproductive ages, are not really desirable participants in vaccine studies, as my colleagues have already told you. They're excluded as part of a protection of women, and the consequence of that forms of protection has been challenged systematically from 1997, and it still persists. But we have to say that at least with COVID-19, because of the rampant fear that emerged and the huge lockdowns that happened, the regulatory frame and the requirements for including women has emerged rapidly, because for lactating women, we have regulation by May 19th, when we started rolling out vaccines by January mid, and for pregnant women by 2nd July, which I think is remarkable, considering the fact that from 97 onwards, in spite of the push and the global bioethics movement asking for including women in all clinical trials as an ethical requirement in the mid-2016s thereabouts, the fact that at least COVID pushed is, I think, something remarkable. A breakthrough, I could say, that we could come up with regulations in this context within a period of 5 to 6 months. That's what makes this important to look at the gender gaps. Next slide, please. Next slide. So what is the gender gap in vaccinations? And I used existing data, and I'll explain how I did that. The red lines represent the the female vaccinations, and the blue lines represent, I'm sorry for being so, conventional in colors, but you have the blue lines for the men, and you can see that almost everywhere, the red line is shorter than the blue line. So I'm using the word gender gap here because the reasons for this gap are not only the biological construction of women, but also because of the various reasons my colleagues have mentioned. The exception is Tamil Nadu. Now, we don't know why Tamil Nadu has more women. We need to make that determination. So also Karnataka, Andhra Pradesh has more women vaccinated. And this is data as of October 1st. And for the denominator, I have used the Government of India's projected population aged 0 to whatever, as long as they live, as of October 1st. So this is how I have computed it. Now, all of this is fraught with problems. Okay, you should not take this as gospel, because neither is the numerator which gives me the number of people who are vaccinated. This is at least one vaccination, not both, at least one vaccination. So you have no doubt as to why overall in India there is a huge gender gap. Barring some random South Indian states, almost every state. And if you have to look at the National Capital Region, look at Rajasthan, look at J&K, look at Gujarat, look at Maharashtra, you can see the gap between the red and the blue lines. So, in fact, overall for most of India, barring Chhattisgarh, which is kind of more or less equal, and it's also important for you people to notice that regardless of where the red and blue lines, the first line that crosses several states, Jharkhand, West Bengal, Bihar, Uttar Pradesh, have not even touched the 50% mark, regardless of for men or women. Vaccination itself has not caught up. So, Dr. Vibhuti, I hope that answers your question about we have less than 2.5 months to the end of the year. And if, some of our major states are nowhere near, to move that figure forward is not only the number of people available to vaccinate, more than 50% of the population, and we've rolled out for 0 to 17 as well. And in fertility high states, this is close to 40% of the population. So you could say that they are the people who are not vaccinated, but I am suspicious that that alone is not going to cover it. We will need some more efforts, and I will talk about those gaps presently. Sir, next. So Jharkhand, Bihar, Uttar Pradesh are reaching the halfway mark, barely reaching it as of October 1st. Tamil Nadu, Chhattisgarh, West Bengal, and Punjab have almost reached to vaccinating at least 60% of their populations. Telangana, Maharashtra, Madhya Pradesh, Odisha, Assam, and Rajasthan are some who are between the 30 and 80% coverage of their populations with at least one dose. Karnataka, Andhra Pradesh, Gujarat, NCT, Delhi, Haryana, Uttarakhand, and J&K have almost covered 80% or more percentage of their populations with the first dose. Kerala and Himachal Pradesh have strangely, if I use the projected population, vaccinated more than the projected populations of October 1st, 2020. This, I have to say, in spite of the fact that the 0 to 17 populations, the regulatory requirement came up yesterday, so they are yet to be vaccinated. These results are from the CoWIN portal, and the Government of India's population projections for 2021, and both could be subject to errors. The latter, that is the projections more, because, if you, as a demographer, I should tell you, Stalwart, who did projections for the World Bank, said if you don't like someone, ask them to do projections. This is Professor K.C. Zakaria, who is the oldest living demographer, who actually educated us about the pitfalls of projections. But in the absence of census, which would have been available, we have nothing else but these projections. And both these states, Himachal Pradesh and Kerala, were subject to massive in-migration from expats in the case of Kerala and from the neighborhood states. For Himachal Pradesh, I have learned from my friends from Punjab. So HP, Himachal Pradesh, as of now, this could be a factor for the excess, because we have 2 million plus people living abroad in other countries, Middle East, elsewhere, many of whom who sought refuge in Kerala during the lockdown period. And that could be the reason for this, projections being outnumbered by number of vaccinations. But also Himachal Pradesh claims 100% vaccination. And as of today, Kerala claims 93% coverage with first dose vaccinations for the above 18 age group as of today. So the projections are also wrong. Kerala government seems to have a different projection. For gender gaps, more men have been vaccinated in India than have been women. The only exceptions are Tamil Nadu, Karnataka, Andhra Pradesh, and Chhattisgarh and Bihar. And only local understandings will help us understand the reasons for this. I cannot offer explanations. Another reason for the gender gap, very important, which has been alluded to by Dr. Medha, is a pregnancy regulatory requirement which emerged only on lactation for vaccinations, restriction, lifted by May 18. So what would have happened to all the people who were pregnant from January till May 18? So there is a backlog there. And then there is for pregnancy, which was lifted only on July 2nd. So what about the women who might have been pregnant? So that lag as a proportion of the total population ranges between 6% to about, about 3% in the total female population. But if you take only women in reproductive ages, it reaches in Uttar Pradesh close to 12% of the women in reproductive ages, who will all have reason for vaccine hesitancy because of our various things, including WhatsApp universities. So even if we assume that we continue to vaccinate women, this is a huge backlog to cover, which we need to take cognizance of. Sir, next. Another possible reason is, the expectation of life at birth for women in India. Women for about 20 years now have been living longer than men. And so they live in this, widowed or other state, they live alone. And I used the longitudinal aging survey of India data of 2018 to project the potential number of women and men who might be living in a single person household. Now, these are 60 plus, so asking them to learn to become digitally equipped depends on education, which is going to be at the higher age, almost non-existent. So you can see here how big the gap is between the red and the blue lines. And these are and in certain states, this is, of the total male population and total female population. It ranges from an all-time low, very low of, 0.1% in J&K to something as high as 1.7% of all people in Tamil Nadu, of all women. So all women, this is not, women in the 60 plus. I actually looked at it from the perspective of all the women, including the newborn people who can be categorized as women. And the gap is huge. So we need to address this group also, because 1% in UP, can you imagine what a huge number that would be? And in India, for women, it is close to 9.9%. 1.3 billion it's about 70 crore women. So think of 1% of that.
Yeah.
Is a huge number. So next. So you have to know this is my attempt at identifying gender gaps and quantifying them. I've used these sources. They are all with huge limitations due to underlying assumptions, differences in reference periods and all of that. But you know, when you're examining vulnerable people such as women, transgender groups, we need to use innovative methods of collating data, applying whatever you have to tell a story, a coherent story. And that's what I've done. Warts and all, this is the story. So we need, sir, please move on. Next. We have to target women if they are pregnant or lactating to dispel the misgivings, to encourage vaccinations, to bridge the gap. Because of this change, you know, they were not all, there's no level playing field for pregnant and lactating women. So there is a Maruthu Kavacham campaign that has been launched in Kerala. We need to launch campaigns which says that ASHA workers will help women to register for vaccinations. There's special vaccination camps, and they're ensuring special days when exposure will be minimal. All kinds of efforts are being made to target women, pregnant and lactating. We have to have a targeted approach for 60+ populations, especially those living alone. We need to identify, approach, and enable women to obtain vaccinations, because the huge, except in Haryana and Punjab, there is a huge proportion of elderly women living alone. And this is like, this group is going to be digitally disadvantaged. For men, there is a need to enhance coverage by, you know, enhancing the access to responses regarding lifestyle practices, which they are a reason for vaccine hesitancy among men, and also enabling labor migrants who are, you know, mobile. It's like if they have had vaccination single dose elsewhere, you know, there's this misgiving, language barriers, to overcome all of it in the place where they are currently found, is because they should not fall between the interstate gaps, and every effort has to be. It's dealing with vulnerable groups calls for need for data to monitor and provide. Lacunae, this is another gap that we need to be bridged. For example, I can't even determine the vaccine status of transgender groups, even though they are mentioned, because of the small numbers. When you have huge male, female, and you have just an arch, you cannot compute anything. So if we need to monitor them, we have to have special efforts considering the size of their populations, because the larger numbers of men and women would serve to mask their presence and render them invisible in large data sets. And that's another thing we need to do for all specific small vulnerable groups. Next. That is it. Thank you. That was it, sir. Thank you.
Yeah, thank you, Professor Mala Ramanathan. You have really done a rigorous statistical exercise using your acumen as a statistician. And I think your last slide was extremely important, that what can we do to breach the this kind of a gap. And your very important learning that one had, that how large data sets of men and women, they completely invisibilize the small vulnerable groups, and we need to be extraordinarily sensitive about that. And with this, I think we have had a very, very comprehensive picture about gender gap in vaccination. There has hardly been any discussion on it. Globally, there have been some discussions, but in India, I think today we have learned a lot from this discussion. Are there any questions? There are participants who are also equally serious about this issue. So if they want to ask any question or expand the arguments or share their field-based experiences, the floor is open to all of them. You can just unmute yourself and speak.
Ma'am, meanwhile, if we can go to Vina, ma'am.
Yes, yeah, Vina, ma'am, yeah. Yes, where is she? Hello, would you like to respond to what Dr. Medha and Dr. Mala Ramanathan have suggested and the issues raised by them? Yeah.
Vina, ma'am, please unmute yourself.
Yeah.
Vina, ma'am, please unmute yourself. Please unmute yourself. Yeah.
We do need to have a positive action plan, because some of the suggestions that Medha made are really good. And also with what Mala presented, it's just an eye-opener to see how we look at things in a very, very um, ways that we can have our insight into these are okay, this is the reason, this could be the reason. So it's important to work along those lines. And as Medha suggested, if we can have the clinics at home, if a lady can't come, it can't be a difficult thing to do.
Yeah.
Because I think there should be a public-private partnership to see through that. Most of us, especially with springing up of so many medical colleges, we have huge areas. We have about 25, 30 PHCs with us. So it can't be a non-doable thing to do if we set our goals on it. So I think we would like to work along those lines in what way we can really materialize this into an action plan. So that is how I look at, and also like what Mala suggested, that some of the states have done really well, like for instance, even Karnataka for that matter. So what are the learnings we can take if we can have an in-depth kind of immersion into what is making people go for it? So if that can be used as a learning for the success of other states, that would be really nice.
Yeah. No, and one very important question is that if in the 60s and 70s, with very limited resources, if we could have a door-to-door campaign for smallpox vaccination or the tuberculosis vaccination, I think it's a question of more of a political will rather than lack of resources. In terms of whether it's a human resources or financial resources, I think India is in a much better position than it was in the 50s and 60s. No? So I think that's a way. So it is doable. Definitely, it is doable. Yeah.
And I think, just one sec, about what you said, totally about political will. We should be able to dissect out the politics of a party vis-a-vis the national interest.
Correct.
And we should not try to swap places, that wherever possible you try to do this. So then there's a credit for this, and then somewhere it would be like trying to emboss pictures on idlis while distributing.
Yeah, that's also.
It's a good measure to do, but then what about people who would really want to be told that you do it because this is why you have to do, than saying that because this is how, these are your beneficiaries, so please be very grateful to them in your life and things like that. So
yeah, that's also there. Yeah, what would you like to say, Dr. Mala? Dr. Medha, would you like to respond? Yeah, as a way forward, what can we do?
Mala ma'am is responding. Yeah,
yes, someone has asked about percentage covered in rural urban areas.
Yeah.
May also reveal the gaps in single women, elderly women, chronic patient women. It's
yes.
From the COVID portal, it is impossible from the dashboard to extract those detailed numerators. I can get the denominators. Usually we struggle with denominators. We have numerators, but it is impossible to, I can get rural, urban, but I can't get it by sex. I can get by age, then I can't get it by sex. So if I get it by sex, I can't get it by age. So it is something which is difficult to do. That's why my data didn't tell you. It only gave you the proportion of women living alone in those ages using glassy data. I don't have how many women got vaccinated among them. I can't compute that.
Yeah, one small question I also thought to ask that, have you also looked into the shares of the population, those who were infected by COVID, by gender, whether they are vaccinating, because that also has to be some gap. Have you also looked into that? Because
no, I haven't, because it is difficult to extract it from the available portal. See, if you need to do stuff like that, we should have been ready from day zero with public health research also rolled out. Documenting such numbers should be readily available to researchers. And I'm sorry to say that we don't have that data. It's not easily accessible even to people in government sector.
Right.
The state, different states have this gender-based COVID affected people, and also the age-wise data. Like Maharashtra has given that data. Maybe overall we don't have, but the gender disaggregated data about COVID patients and the age group, different cohorts in the age group. Certain states have, not all states.
Yeah, so you can't do it as a transnational.
Yes.
But I want to add that one little thing, Dr. Arun Kumar, if you will permit. Just a tiny thing, Dr. Vibhuti.
Yeah.
You know, the Kerala government, we were a bit, you know, aghast in the beginning that they actually went hammer and tongs at someone who passed on, you know, scientifically unsound information through WhatsApp. They threatened arrest and all sorts of things. And, you know, it was seen as, what is this? This is trivial, but that was a very, I think, useful in, you know, challenging these potential WhatsApp forwards Dr. Medha referred to in Kerala, which has resulted, in fact, at one stage we were helping everyone to find vaccination centers because it was so difficult to get vaccines, but that is not true. And almost everyone has got their first dose and are waiting that, you know, period. So it helps political will. Sometimes at that time we were like, it's ruthless and stuff like that, but you know, now in hindsight, it seems like a wise thing to have done.
Right. One small question also I thought to ask Mala ma'am, since we're talking about statistics, but you know, from NHA and CoWIN, ma'am, if such a senior and you know, serious researcher like you ask for, they will provide the data. I also thought to ask you, is there any biases in terms of the vaccines like Covaxin, Covishield? Now we have other vaccines also. How do you see any gender inclination in that sort of thing? Have you found anything?
Sputnik also.
Also Sputnik, no, actually, it's not so much gendered. You see, it's just governments itself who have taken a stance. The Kerala government, for instance, took a stand against Covaxin in the beginning, saying unless it is approved by the central government for certain reasons, it would not accept it. So in the first round of rollout, Covaxin was not in the vaccination options for us in Kerala. Now that itself resulted in, is it safe kind of questions. You know, this is, part of it is self-created. Of various arguments and rolling it out differentially, giving differential status. All of that has also fed, you know, popular notions, rightly or wrongly, of different vaccines. So, you know, it's difficult now to disentangle those threads.
But the southern states had multiple sourcing, no? They use Sputnik, they use Covaxin, they use Covishield, all, no? So as compared to many other states who were totally allergic or totally like hostile to using certain.
We are a tiny union territory. We didn't get any choice. Beggars can't be choosers. We were given only Covishield and that's it. There were no options available in our state. We are a tiny union territory with a population of 12 lakh odd. So whatever we got, we took.
Okay. Yeah, I understand.
Ma'am, there is a question in the chat box, if I may address that.
Please. Yes. Please address that.
The question is, what is the case of single women, elderly women and chronic patients, women in vaccination? It may reveal whether such sections are neglected, rejected or hesitant to get vaccination. Like, as I already mentioned, they say if Muhammad cannot reach the mountain has to go to Muhammad. So probably that is the way forward. Because if we are very serious about addressing this gender gap, we really have to move mountains. It doesn't, let me make it very clear that it's not just political will which is going to move mountains. It all depends on all of us working together. Like Mala ma'am already said, the private, the public, everybody has to put their arm together, and much hand holding is required if we want to make this a reality. Unless each one of us contributes towards this, this is not going to happen. I'm sure that many of us have heard that in places like Bangalore and all, there have been apartments, there have been retirement homes where the welfare associations have come forward to make sure that such camps are organized. In fact, there's a friend of mine who has organized, he's running the Address Health, which is an organization in Bangalore. They have taken this Sputnik 5 vaccine from place to place, addressing different offices, They've gone outside Bangalore, they've gone to Hubli, they've gone to several parts of Karnataka, to different workplaces, different apartments, different places into the community with their incubator kind of fridge, which they have innovated and made one of their vehicles into a fridge kind of thing, which by their own innovation they have created. So that is the need of the hour. We need people like Dr. Anand Lakshman, who runs Address Health, who go into the community, innovate and actually reach out to people for this. Of course, many of these vaccinations in the community are charged, but I do believe that it's a right of each one of us to get free vaccination, especially like they mentioned in the chat box, the marginalized, the single women, the chronically ill. I think public should be made available free vaccination, but it may not be easy without funds being available. It's not only the government which should put its foot forward. We need even the public to come forward. We need NGOs. We need all the corporate social activity of all the IT companies, the different firms which are there, the software industry, the other industries to come forward and contribute towards this noble cause.
And also so many MPs, MLAs and corporators, they are in Bombay. Each
Absolutely.
corporator gets 5 crore rupees for area development. And most of it remains unutilized. So why not to use the unutilized money by this area development? This is also, and they have done, there are many who have done also this kind of work. Yeah.
So because can I add a small thing about, because in the state where I live, it's not like we have too many apartments. We do, but not many. So many of the elderly who are living alone are scared of criminals and, bad people coming. So even if you come and say vaccine, they will think that it is a bad thing. Yeah. So, there is a two-edged sword for that kind of thing. And I noticed that. So we had to overcome that with, neighborhood. Like we have a word, I'm using neighborhood. In the neighborhood, we set up saying you come only to that place. That is enough. Freely we will give vaccine. Because then they'll safely lock their house and come. But if you go to their house, they don't know you. So, the other one which we did is our local women, we have neighborhood network women who told them, you come to this place. So it was our, what we call ward effort. In Kerala, we have local elected representatives who are part of our life.
Correct.
So,
in Bombay also, the decentralization work, when you had a ward-wise committee and war rooms in ward-wise and facilitators, helplines, backed up with FM radio and local cable channels.
WhatsApp groups, local WhatsApp groups which help. So those and all were very, very helpful. Yes. I have to point out that this setting up camps in one place needs a backup of reassuring them to come there. Otherwise, door to door is okay for pregnant women living embedded. But for alone living elderly, that is not a good approach because they are scared.
They are scared. It's risky. Yeah.
So that is why. So, for each segment, if we had a private enterprise and market research had been done, we would have done market segmentation and had a better approach. Because it is a public health thing and only government and there is no market research done on this, we don't know. But I can point out from my knowledge locally of this small segment. So each segment needs to be approached differently.
Yeah, and also the self-mobilization of that special interest group, like wherever they are, whether it is under Janaswasthya Abhiyan or whether they are the women's organization or some Rotary clubs, Lions Club in Bombay, all sorts of civil society organizations, when they specially focus on the local specific reality, then things move, no? So I think those efforts are, so it is a non-market because that is mainly, it comes in either under philanthropy or it comes under the community-based work and all that, but it has worked. But I think we need to replicate these models all over India. So then only we can, I think, address the issue. So thank you very much all, Dr. Vina Vaswani, Dr. Medha Rajappa and Dr. Mala Ramanathan for such an interesting, very, very educative session today. And you all three of you made such studied presentation and also like you gave us such a very detailed understanding of the issue. And now I would like to end with the thing that when World Health Organization has also advised the nation states to come up with a more comprehensive program. And as I think Dr. Medha also said, that we need to have a multi-pronged approach. And I think all civil society organizations, NGOs, health workers, and other charitable organizations, along with the state. So state and non-state actors, all of us have to join the hands, and then only we can achieve the target of vaccination. In the recent report, the World Health Organization stated that and I quote, that understanding how gender roles, norms, relations, and gender inequality influence access to and demand for vaccines in different contexts is critical for expanding reach. It also, however, the WHO report also stated that gender-related barriers must be addressed in planning and rollout of vaccine distribution to reach everyone, especially those who are marginalized. Women in general are law-abiding. We have seen that. We understand that all the safety rules women have followed, whether it is wearing of a mask or the guidelines which are given in a palatable language. And that's why the door-to-door vaccine, partially, yes, for the that is also important. But when it comes to the senior citizens, I think we need to have a more trust building which is required. And CSOs, civil society organization, community-based and neighborhood organizations, as Dr. Mala Ramanathan suggested, should also be encouraged to be active. Misinformation campaign needs to be tackled, multi-pronged approach of using skits and drama and flash mob, and students of medical colleges and other universities, they can also play a very important role in countering the misinformation campaign. And the pro-vaccine campaign needs to be more very, very systematically and consistently promoted. Women's organizations have demanded that the state will have to take responsibility for women's vaccination because their families will not. And through official media, FM, radio, television channel, we change the message around vaccination. They don't say that get vaccinated, but rather say that get your whole family vaccinated. So emphasis is on whole family vaccinated. That should be the message conveyed to the community. Working with the whole range of frontline workers such as local government officials, women elected representatives, CBOs, NGOs, CSOs, along with ASHA and Anganwadi workers becomes very important, who are already, ASHA and Anganwadi workers are already overburdened. At the same time, it is extremely important to ensure steady supply of vaccine, because states after states complaining that suddenly, like in Mumbai also, we have seen that people go, they queue up, and then they are told vaccines are over. So I think the steady supply is very important. There are certain states where you get steady supply, like Gujarat doesn't have shortage of vaccine. There are many other reasons for vaccine hesitancy, but the supply is not a problem. While in our Maharashtra, there was a tremendous shortage, scarcity of vaccine. Finally, the state government used its own money to buy vaccine directly from the suppliers. So increasing vaccine supply is also key, and at a time of a shortage, and women are particularly likely to get left out if there is a scarcity. So I think we need to address both the supply side as well as the demand side. And last, most important thing, that there needs to be universalization of vaccination. It is the duty of the state to provide free vaccination to all citizens of the country. And I think that we again emphasize as a public health advocates. And I would now request Dr. Arjun Kumar to take over.
Thank you so much, ma'am. So such a stimulating session today evening. So yeah. To the formal vote of thanks, I invite Anshula Mehta to do the same. Anshula.
Yeah.
Thank you. I am Anshula, Senior Assistant Director at IMPRI. And on behalf of the Gender Impact Center, I would like to really thank all of you for joining us today for this web policy talk on the gender gap in vaccination. We thank our speaker, Professor Vina Vaswani, for taking out the time to be with us and to deliver this very informative presentation on a topic of such crucial importance in the current times. Thank you, ma'am, for being with us. We are grateful to Professor Vibhuti Patel for joining us as the chair for this session and for really shaping the discussion with her valuable inputs. Thank you, ma'am. We are grateful to our discussants, Dr. Mala Ramanathan and Dr. Medha Rajappa, for joining us and for sharing their perspectives and their analysis on the theme. Thank you very much. And of course, we are grateful to all the participants who joined us here on Zoom or on Facebook Live, or will be watching us later on YouTube or listening to us on our podcast. We hope that you continue to tune in to future episodes of Gender Gaps and our other web policy talks as well. Thank you again, and I wish you all a very good evening.
Thank you. Have a nice evening. Thank you very much.